Thank you, Jeff, for that introduction, and thank you everyone for taking the time out of your very busy day to join me for my webinar on high-risk hereditary breast cancer. We will review what it means to be high risk, the basics of breast cancer genetics, the genes and their associated syndromes, past what we know about BRCA1 and 2, the importance of genetic testing for hereditary breast cancer, and then a few case examples that will really highlight how this can be helpful to you and for your patient. And then I'll review the testing options here at Pathway Genomics. Breast cancer is the most common cancer in women, regardless of race or ethnicity. I don't think anyone on this call is surprised to hear that. In the U.S., 1 in 8 women will be diagnosed with breast cancer, which is an average lifetime risk of 12%. And while all cancer is considered genetic, it's not all hereditary. Only a small fraction is actually heritable. And we'll review that a little bit more in the upcoming slides. And when we talk about high-risk breast cancer, it's important to define that. So typically when we're looking at a family history only, one affected first-degree relative increases a woman's risk twofold, while 2 first-degree relatives increases that risk threefold. Hereditary mutations can actually increase that risk as high as 5 to 7-fold. So this slide is just kind of showing how much breast cancer really is hereditary. So that largest slice of the pie, that dark pink, that's the sporadic, about 70% of cancer. And then 15 to 20% is what we call familial. So we think it's a combination of low penetrance genes and environmental factors that explain clustering of cancers within families. In only 5 to 10% do we really believe that it's hereditary and we can find one single gene increasing the risk for cancer within the members of that family. So what does it mean to be sporadic versus hereditary? So sporadic mutations or sporadic cancer is caused by mutations in our somatic cells. And our somatic cells are every single cell in our body except for our egg and our sperm. So those mutations cannot be passed on to our children. They are non-heritable. And we think that the sporadic mutations are caused by a variety of factors, basically any carcinogen that you can think of. On the other side, hereditary cancer is caused by mutations in our germline cells. And our germline cells, those are our egg and our sperm. Those mutations will be passed on to our offspring. Well, it's autosomal dominant, so each child will have a 50-50 chance of inheriting a germline mutation. And one thing to keep in mind is that a single mutation only increases that person's risk for getting cancer. It does not mean that they will develop cancer. And there are some changes in our genes that are either benign or are variants of uncertain significance. So we don't know what they mean. We don't know if they cause cancer or not. And we'll get into that a little bit more. We do have a fantastic webinar by Adrian Vilalta, the head of our genetics team, on how we do variant classification here at Pathway. So I'm not going to go into that in much detail today, but please don't hesitate to email me or ask questions at the end of the webinar. So when we think of cancer development, we think of it using Knudsen's two-hit hypothesis. So I mentioned that it's autosomal dominant. So to have the condition, to have the increased risk for cancer, you only need to have inherited one mutation. And so we know that in every single cell of our body, we have 2 copies of every single gene. And so having a mutation in one copy means it's autosomal dominant. But we do think that you need to acquire a mutation in that second copy in order for cancer to actually develop. And so that's why the hereditary mutation only imparts an increased risk. And so in this analogy with the car, the tumor suppressor genes are kind of like the brakes on the car. So BRCA1 and BRCA2, those are the brakes. They slow down cell growth. Oncogenes are like the accelerator. So if we lose both of our brakes, so if we have either 2 acquired mutations or 1 hereditary and 1 acquired mutation, then all we need is that proto-oncogene to become an oncogene and cancer will develop. To look at it a little bit differently and how it actually happens in the human body, you can look at this slide from left to right. That's the sequence of time. And so one cell is what starts the whole process of tumorigenesis. And so we have the inactivation of the tumor suppressor genes, and then the cells begin to proliferate. And then we acquire mutations that inactivate our DNA repair genes. And this is a really important step to tumorigenesis because our cells are rapidly copying DNA all the time, while we're sleeping, while we're awake, while we're talking, constantly replicating DNA. And mistakes in that process occur all of the time, but we have our DNA repair genes, and their job is to make proteins that fix that damage. And so if we lose the ability to fix that damage, then the cell essentially becomes completely unstable and will continue to acquire more mutations and genomic instability, which leads to metastatic disease. So again, just to review autosomal dominant inheritance, each child has a 50% chance of inheriting the disease predisposition, and genetic mutations are equally transmitted and inherited by both men and women. And so the disease risk will be present in every single generation, but we don't necessarily see someone affected in every single generation. And so that's something to keep in mind. And here I've just kind of put in a slide to show you a brief kind of overview before we get more in depth about these genes and the syndromes that they cause. So on the left, you can see the general population risk for breast cancer of 12%. And then if you just look across, these are the genes on our high-risk panel. They are all increasing a patient's risk for cancer much higher than that general population. And then here's another way to represent those genes. So you can see it's been boxed in the circle in the top left. So we've got risk estimate on the y-axis and minor allele frequency, which basically means pathogenic variant frequency or mutation frequency, however you choose to verb that, on the x-axis. And so this might seem intuitive once you look at it, but basically what this is saying is as the risk gets higher, it's going to be less frequent. So we're looking at these very rare syndromes that increase the risk very high. There are other genes that we know of that are associated with risk for developing breast cancer, and we put them either in the intermediate or low risk frequency, but they are going to be a little bit more common. So the first syndrome that I want to review is hereditary breast and ovarian cancer syndrome, because I think most of us are familiar with this syndrome. It is caused by mutations in BRCA1 and BRCA2. And you can see here that the cancer risks for women are significantly higher with a mutation in either of these genes. So we have breast cancer risk as high as 50 to 80%. Second primary breast tumor is elevated. Ovarian cancer, specifically with BRCA1 carriers. There has been melanoma seen, and pancreatic cancer. For men, we see an extremely elevated risk for breast cancer, although it's still not very high when we compare it to a woman's risk, but the general population risk for a man is 0.11%. So with a hereditary mutation, that's going to increase as high as 10%, which is a very significant change. And then there is a risk for prostate cancer, again, the melanoma, and pancreatic cancer. The second condition I want to discuss is hereditary diffuse gastric cancer, which, just like it sounds, increases a patient's risk for gastric cancer, specifically diffuse gastric cancer. And it is associated with mutations in CDH1. And there actually was a recent article in JAMA last week that clarified these risks a little bit more, but I apologize, I had already made the slide set. But it's Hansford et al. And this has been the largest cohort studied so far with CDH1 mutations. And what they found was that by the age of 80, The cumulative incidence of gastric cancer was 70% for men and 56% for women. And then women also have this risk for breast cancer, specifically lobular, and they found a 42% incidence. So not too far off, but a little bit lower than the risk that we previously were quoting. And it's important to know that there are family histories with no gastric cancer, and all we see is the lobular breast cancer. Just to keep that kind of in the back of your head. PALB2 is kind of, I call it the new kid on the block. It was always known to be an intermediate risk gene, but very recently, I believe it was last August, this paper by Antonio et al. Came out in the New England Journal of Medicine, showing definitively that this is a high-risk gene. And so what they found was that for those with no family history, there was a 33% risk for breast cancer. And for those with a high-risk family history, it was 58% risk for breast cancer. And PALB2 is called the partner and localizer of BRCA2. So some people are even calling it the BRCA3, although it's primarily used in the media and has not really been adopted by the scientific community. And it is important to note that also, like BRCA2, there are autosomal recessive mutations within this gene that lead to a condition called Fanconi anemia. And I'm not going to review those conditions today. The next syndrome is P10 syndrome, P10 or Cowden syndrome, also called P10-related hamartoma syndrome. And so this condition is characterized by multiple non-cancerous tumor-like growths called hamartomas and an increased risk for cancer. And so these hamartomas typically develop on the skin and the mucous membranes, and typically by the late 20s. And there are several cancers associated with syndrome, including breast, thyroid, endometrial, colorectal, kidney, and even melanoma. And there are other symptoms that are often noted in the family history, such as macrocephaly and learning disabilities, such as autism, as well as mental retardation. And there is another condition called Bayen-Riley-Ruvalcaba, which is also associated with P10, but I won't be discussing that today. STK11, previously LKB1, is a gene associated with Peutz-Jeghers syndrome, and this is also characterized by the development of hamartomatous polyps, but in the GI tract, an increased risk for cancer. So the children may have this mucocutaneous discoloration, but that typically resolves by the teen or adult years. But there are very significant cancer risks, so breast, ovarian, GI tract, pancreatis, and even cervical cancer. And last but certainly not least is TP53, which is associated with Li-Fraumeni syndrome. And this one, as NCCN describes it, is a highly penetrant cancer syndrome with a high lifetime risk of cancer that is characterized by a wide spectrum of cancers at a young age. So this is kind of the cancer gene. And we know that it accounts for less than 1% of all breast cancer for hereditary mutations, but with somatic mutations, it's about 20 to 40% of all breast cancer. So if we do tumor analysis, very often we're going to find this gene mutated. And I remember the cancers associated with this syndrome by its previous name, SBLA syndrome, which stands for sarcoma, breast, brain, leukemia, and adrenocortical carcinoma. And a person with this syndrome has a 50% risk for one of those cancers by the age of 30. And it's, depending on the study you see, I've seen it quoted as high as 100% lifetime risk, but we say 90% cancer risk by the age of 60. So very significant cancer syndrome. And it's important to note that about 7 to 20% will have no family history, meaning that a de novo mutation occurred. And so what that means is that the person is the first in their family to have the mutation, which occurred in either the egg or the sperm that created them. But it will then be hereditary, so each of their children will have the 50% risk of inheriting that gene. with that mutation. And there is also a Li-Fraumeni-like syndrome caused by CHEK2 mutations, which is considered a more intermediate risk breast cancer gene. So as I've kind of alluded to, there are lots and lots of genes associated with cancer risk. I like this diagram by Kobayashi et al. Just because it kind of gives you a good overview of how all of these things interact together. So we have BRCA1 and BRCA2 and POLB2, RAD51C, all interacting together. And then with the Fanconi anemia pathway, and then you have your DNA repair genes, CHEK1, CP53, and then you have the Lynch syndrome genes. So all of these things, are interacting, and genes are recipes for proteins, and that's what's ultimately happening. We're looking at the interaction of these proteins and the development of cancer. So as a clinician, the first thing you need to ask yourself is, why would I test a patient for hereditary cancer syndrome? What is the benefit? Well, there are some direct patient benefits. For example, surgical and treatment decisions. A woman with a hereditary cancer might decide to do a double mastectomy rather than the lumpectomy, or be more aggressive with the chemotherapy. And it might change their screening and management for other cancers, specifically those syndromes like P10 or TP53, where we have very specific cancer risks. And for some, it just provides information, which is huge, even though you can't really quantify that. There are indirect patient benefits, obviously familial implications. So once a woman or man is identified to have a mutation in one of these genes, we can then offer testing to all of his or her first-degree relatives. So that can be siblings, parents, children. I hear a lot of women say, I don't really care to know this for myself, but I want to know for my daughter. And I think that that's an extremely valid reason to pursue testing. And for some, it's just very psychosocial. So perhaps they had, a lot of anxiety, and finding out that they did have a hereditary mutation, while that might be perceived as a bad thing, it can make a lot of that anxiety dissipate, because now they have an explanation, they know why, and they no longer blame themselves for having caused this. And it also gives them a sense of control, because we have management guidelines. Now we know what to do. Now that we know this is the cause, we have a plan of action. And for some, this may even factor into their family planning. There is a procedure called pre-implantation genetic diagnosis, which can be done in conjunction with IVF, which obviously is not available to everyone, but it can be an option for those patients that can afford it and don't want to pass a mutation like this onto their child. Now, we mentioned that hereditary cancer is rare. It's only 5 to 10% of all cancer. And so we're not going to offer testing to every single person. It just isn't feasible or affordable. So we're only going to test those that have a high chance of having a hereditary breast cancer. And so the things that we're looking for early onset breast cancer under the age of 50, multiple relatives on the same side of the family with the same type of cancer. That's very important. I think a lot of times we see family histories where the cancer is on both sides, but not really no discernible pattern. Bilateral or multiple primary breast cancers in the same individual. Diagnosed with both breast and ovarian cancer or other related cancers. Triple negative breast cancer is actually very, very common with BRCA1 carriers. So triple negative is a huge red flag. And then obviously male breast cancer or other rare cancers. And we do know that BRCA mutations are more common in the Ashkenazi Jewish population. And so that's a red flag as well. Just to give you a comparison, in the general population, we say that 1 in 400 to 1 in 800. So very wide, wide range, depending on the paper you read. So we'll just say 1 in 400 individuals will carry a BRCA mutation. Within the Ashkenazi Jewish community, 1 in 40 of those individuals will carry one of 3 founder mutations within BRCA1 and 2. And I'll touch on that a little bit more in the upcoming slides. So now you know what red flags to look for, but maybe you're still not sure. Where do you look? Well, I always direct people to the National Comprehensive Cancer Network. So NCCN has set testing criteria, which we do follow to qualify people for testing. And also, they make recommendations. So once you find a positive, there are guidelines to follow to help that patient. And then each insurance company actually has their own criteria. For example, Medicare will only cover testing for those that have a personal history of cancer. Insurers like Cigna require genetic counseling before they'll cover the cost of testing. So it's important to know those things as well, and encourage your patient to ask their insurance company before testing. Another great resource is the National Society of Genetic Counselors. Anytime I have a physician or a patient calling me with questions, I try to connect them with a local counselor that specializes in cancer. And the way to find one is to go to nsgc.org. And on the bottom right of that screen, there is a Find a Genetic Counselor tool. So that's a great resource. And of course, the genetic counselors at Pathway are always available for consultation. NoBRCA.org is another great website for providers. They have a tool, a family history tool that you can even incorporate in your EMR if you like. The Jackson Laboratory actually has a great CME course for physicians that I would recommend taking just to learn how to take a proper family history, because that is often the key to identifying the right test for the patient and getting insurance coverage. And again, if you have any questions about that, please don't hesitate to consult a genetic counselor with Pathway or outside of Pathway. So now I just want to review a few case examples to kind of get you acquainted with what this looks like in the clinic and how this can be helpful. So this first one is a very classic BRCA family history. So our patient comes to us, she's 56, recently diagnosed with breast cancer. Oh, I'm sorry, just to get you oriented, this is a pedigree. The circles are women and the squares are men. And so the circles that are colored in black are affected individuals. And we always use an arrow to identify our patient or our proband. Okay, so again, our patient is a 56-year-old woman just diagnosed with breast cancer. Alone, she does not meet criteria for testing. So we need to look at her family history. So we ask her, anyone else in your family with breast cancer? And she tells us, yes, I have a sister that was diagnosed with breast cancer at 48. Now she meets criteria and we want to test her. Now, outside of how this could impact her health care, we need to look at who else this is going to help, because when we get that test result back, it's good to kind of give her this information before ordering the testing, because when we get this test result back, we're going to recommend who else to test. And she doesn't have any children, so she might think that it ends there. But we see that obviously her sister should be tested, and we can test her just for the known familial mutation if one is identified, which is much more affordable. And she has a brother with a 20-year-old daughter. Now, that 20-year-old daughter would have not had a reason to get tested unless there was a familial mutation identified. Now, if we have one identified once we do testing, we can offer that to her brother and to her niece appropriately. The second example, well, I'll let y'all guess what it is. So I apologize, it looks like the arrow is saying our proband is the 41-year-old because I put the ages to the right, but our proband is actually the 43-year-old diagnosed with breast cancer. She has an older sister that was 50 that had a total hysterectomy. We have no idea why, just what our patient told us. She has a younger sister that's 41 with 2 daughters. She herself has a 25-year-old son. She has a dad with prostate cancer, but at a relatively, normal age, so not necessarily a red flag, although prostate does go along with BRCA. So we might be thinking that. And that's all we really know at this point. So we order a panel, and when we get it back, we find that she has a P10 mutation. Now we tell her everything that goes along with P10 as far as autism, and she says, "Oh my gosh, I have a nephew that's 12 that has autism." And then we start thinking that her sister's hysterectomy makes sense. Maybe it was due to some endometriosis or even endometrial cancer that her sister just didn't share with her. It's very common for family members not to talk about their diagnoses in much depth. Um, but I like to show this example because the fact that she was diagnosed at 43, she automatically meets NCCN criteria for BRCA testing. But if we had only done BRCA1 and 2, we would not have found a P10 mutation. So here's a case where panel testing really was important. And we do offer it as a reflex. So it doesn't have to be ordered right away. We can start with the BRCA1 and 2. In my last example, this is a patient that I actually saw when I was a student rotating at UNC Chapel Hill. And this was actually a really difficult case for me because the patient was younger than myself. So she was a senior at UNC. She was diagnosed with breast cancer at the age of 22. She came to see us with her mom and dad. There was no appreciable family history. You know, her mom's parents had died relatively young in a car accident, so perhaps there was something on that side. The dad's family history was negative for everything, pretty much. So without knowing what to do, she had already been tested for BRCA and was negative. A lab had actually just come out with a panel of 10 high-risk genes, and we ordered that panel and found that she had a TP53 mutation, which did explain the very young onset. And so this case always reminds me about that very high de novo rate for TP53, and that often the first person you see in a family with Li-Fraumeni syndrome is a young woman with breast cancer, because breast cancer is so common. And I've even heard cases from other labs where they ordered a panel and the patient was found to have both a BRCA and a TP53 mutation. So this is a case where I probably would have ordered just the panel to cover all of my bases and not done it as a reflex. So then we need to discuss how is this actually going to change the medical management for my patient, because ultimately a test is not useful if we're just going to continue to do the same thing. And so I don't want to go through every single syndrome today, but these guidelines are available online, or I can assist you with locating them. You can join NCCN for free and download all of their guidelines. So these are the actual guidelines for Li-Fraumeni syndrome. As you can see, they're very long and very complex. So I wanted to highlight just a few of the most important aspects in my mind, the things that kind of stick out the most. So one is very obvious. We're going to discuss risk-reducing mastectomy, and we're going to counsel as far as how that's going to lower her risk and how that's going to protect her from developing more cancer. And we're going to recommend an annual comprehensive exam with a very high index of suspicion for rare cancers and second malignancies, specifically doing careful skin exams and neurological exams looking for those brain tumors. And if possible, we want to avoid radiation therapy, because radiation therapy can cause more DNA damage and increase that risk for cancer even higher in an individual with Li-Fraumeni syndrome. We're going to recommend that she consider a colonoscopy every 2 to 5 years, starting no later than 25 years of age. And this, to me, I know a lot of people don't think that this is a big deal, but to me, there's now an opportunity to participate in research trials. And so the way that NCCN puts that is they say, discuss options to participate in novel screening approaches using technologies such as whole body MRI, abdominal ultrasound, and brain MRI. To me, that's huge. And to a patient, that's a huge opportunity they would not have had did they not know about this mutation. And to learn more about current research studies, you can visit clinicaltrials.gov or email your local genetic counselor, because again, they are great resources and typically are aware of what's going on as far as research. As I mentioned, we have a few different options here at Pathway, so we can do that single site testing when we have a known familial mutation. BRCA true Ashkenazi Jewish is looking for those 3 most common Ashkenazi Jewish mutations. I mentioned that everyone in that population has a 1 in 40 chance of carrying one of those 3 mutations. And those 3 mutations actually account for 95% of BRCA mutations in that population. So a much more affordable test than the full sequencing and very high detection rate if that is their background. So I always like to start there with an individual with Ashkenazi Jewish ancestry. BRCA True is the full test, so full sequencing and deletion duplication analysis of both BRCA1 and 2. BRCA True Ashkenazi Jewish with reflex to BRCA True. So if we don't find one of those 3 common mutations, we will then do the full sequencing. Our Breast True high risk panel is full analysis, sequencing, and deletion duplication of the 7 genes that we discussed today: BRCA1, BRCA2, CDH1, PALB2, PTEN, STK11, and TP53. And then, as we discussed, BRCA True with reflex to Breast True. This can often be the most effective way to do testing, primarily because BRCA1 and 2 do account for the majority of patients with high-risk hereditary breast cancer. And if we don't see a BRCA1 or BRCA2 mutation, then we do the other 5 genes, and we do not bill or anything until the full testing is complete. Just to give you an idea of our technical specifications, we do use next generation sequencing on an Illumina platform, which is top of the line. We get a minimum of 25 reads for each nucleotide or each base pair, but we get an average of about 3,000 to 5,000. And we sequence 20 nucleotides into the intron. Now, anywhere that we get less than 25 reads, we will go back and do Sanger backfill. And anytime we identify a variant, which is just a change in the DNA, we will use Sanger chemistry for confirmation because Sanger chemistry is still the gold standard. And then we have a fantastic variant classification team, again, led by Adrian Vilalta. And we do have a short webinar, about 15 minutes on that as well, that you can look at to learn more. And we do complementary familial studies. So when we identify a variant of uncertain significance, we will provide an application for the familial studies, and a genetic counselor will review the family history and identify who in the family is most informative to test. And then we will offer them testing at no charge. And that provides information not only for the patient's family, but for us as well. And we do contribute all of our data to the public databases such as ClinVar, run by the NIH or NHLBI. We use ArrayCGH to detect large deletions and duplications, and we accept both blood and saliva samples. And now at this time, I want to truly thank you for joining me today, and I hope that you enjoyed the webinar and learned a little bit more. It wasn't everything you could possibly know. That would take days, but I'm happy to answer any specific questions that you have today through the chat, or you may email me directly at sarah.wienke, W-I-E-N-K-E, at pathway.com, and I would be happy to answer your questions and get you connected to the right people. Thank you so much, and I hope you have a great day.